CEO of the Jordan Health Aid Society International, and Aryiana Jawad, who's also a doctor and founder and president of the Iraqi Kurdistan Society of OBGYN. We're having a little technical difficulty with Dr. Ajlouni right now, but we're hoping you can see him on the video grid. We can see his face. We're hoping to be able to connect with him shortly. So the lineup is also including a number of really great discussants to help us talk through what's the situation is. I have Dr. David Walton with us, who's president and CEO of Build Health International. We have Dr. Larry Ronan at Massachusetts General Hospital. And we have David Harden, who's managing director of Georgetown Strategy Group and who's former assistant administrator of USAID, having led the missions in West Bank, Gaza, Yemen, and Iraq in the past. So we have lots of rich discussion today, and I'm going to pass over to start to Dr. Amir Maharib to give us an update. Thanks, Amir. Over to you.
Thank you, Louise. I thought I would start by giving kind of a scientific update on where we are with hydroxychloroquine and chloroquine in COVID. It's something that we've talked about in past panels on this session, and certainly it's of relevance to low and middle income countries, certainly of relevance because these are drugs that are widely available in the Middle East. So if we go to the first slide, as a background, hydroxychloroquine and chloroquine have a rational basis in use in SARS-CoV-2, the virus that causes COVID-19. They both exert a broad anti-inflammatory effect, and they have kind of a broad antiviral effect. Essentially, they stop the virus from entering, from binding to the receptor that it uses to get inside a cell, and it also stops entry into the cell. They're widely available, they're inexpensive, so it made sense for them to be considered as treatments as this pandemic started. Some problems with it is that in vitro experiments have shown that they need something on the order of micromolar concentrations to have their antiviral efficacy, which gives it a pretty narrow therapeutic window and kind of questionable efficacy at different stages of the actual infection itself. And then, of course, neither hydroxychloroquine nor chloroquine have ever actually shown to be efficacious in humans for any virus that they've been studied against. Very briefly, we'll go to the next slide and think about what evidence exists so far for the use of these drugs in against SARS-CoV-2, against COVID-19. The most talked about study is this open label study that was in Marseille, where hospitalized patients with COVID-19 infection were offered hydroxychloroquine. Their primary endpoint was clearance of the virus by serial testing. So they would do nasopharyngeal PCR tests every day or every other day and try to find at what point the test converted negative. They enrolled 42 patients. 16 were considered controls, 26 were given hydroxychloroquine, and of those 26 patients, they analyzed 20 in their final analysis and found that of that 20, half of them had what they called a virologic cure. Again, just their PCR turned negative at day 6 of therapy. If we look at the next slide, there were fundamental problems with this study. The control patients were largely treated at a different site than those given hydroxychloroquine therapy. The control patients had higher baseline PCR loads, so probably had higher levels of virus in their nasal passage at the start of the study. So this could have just represented a natural decay of the virus. And the 6 patients who were considered lost to follow-up were either in a category of transfer to the ICU, or they had died, or they couldn't tolerate the drug and they stopped taking it. And so ordinarily those would have been considered in the final analysis as an intention to treat analysis, but here they were excluded. So this is a very controversial study, but it was kind of used as the standing evidence with cases and controls that we have published in a peer-reviewed journal right now. If we go to the next slide, There is a preprint, so it has not yet been peer-reviewed, a study of 62 patients in Wuhan, where they used a more clinical endpoint, saying the time to clinical recovery. Based on that preprint, there are, looks like, some inconsistencies that hopefully will be sorted out in the peer review process, but their results suggested that hydroxychloroquine was efficient in mild disease. Several large clinical trials are underway, and so hopefully we'll have answers there soon. And then, of course, many people have raised concerns about the publicity of the limited data or limited evidence we have. There have been hospital admissions throughout Africa and North Africa for overdoses of hydroxychloroquine. There have been supply chain shortages. We know that hydroxychloroquine may have arrhythmias or other adverse effects when they're used with azithromycin. And then, of course, drug shortages in places that really require chloroquine and hydroxychloroquine for other indications. And then to my last slide, I would say that, you know, many national treatment guidelines are incorporating hydroxychloroquine and chloroquine for an absence of any other evidence-based therapy. So, for example, the just released national treatment guidelines from Egypt's Population of Health and Population, Ministry of Health and Population, includes hydroxychloroquine, azithromycin, oseltamivir, which is a drug used against influenza, ascorbic acid or vitamin C, and paracetamol or Tylenol. Again, none of these drugs, and there really is no therapy that's been proven effective against COVID-19, but without other options and without effective therapies, these are what are currently being reached for right now, not just in Egypt, but in many parts of North Africa and the world. So I'll stop it right there for our my comments on just updating us on hydroxychloroquine.
Thanks, Dr. Maharib. And I'd just let our guests know, that attendees know, if you'd like to pose a question to any of our panelists or discussants, please go ahead and use the Q&A feature in the Zoom conference, and I will be happy to pass those questions on. So Dr. Maharib, can you just, as an infectious diseases doctor at Mass General, can you just tell us right now, are we using hydroxychloroquine at Mass General for patients with COVID-19? And are you saying it should be used, or just saying that it should be used under the guidance of a clinician who's trained? Can you give a bit specificity on that, in your opinion?
Yeah, here in Boston, it is being used with other antiviral agents, with the knowledge that it is may not be effective. I mean, we also know that patients who are in the beginning of their syndrome may have milder disease with active viral replication. And that might be the most appropriate time to be using an agent like hydroxychloroquine or antiretroviral agents, which are also being used. As patients progress to the more inflammatory phase, where they require intubation, where they are in acute respiratory distress syndrome, there are a lot of clinicians who believe that this drug is not as useful then. The trigger has already been pulled, and the virus is less of an issue as the just inflammation in the body. So at Mass General, it's being used. It's also being studied as post-exposure prophylaxis for people who have been exposed to COVID but have not yet developed symptoms. And I think that's where the promise will be for this drug. I don't think it will be as useful in patients who are in respiratory distress.
Great, thanks. So we need to stay updated on the science in that. So thanks so much. We're going to pass on to Dr. Tara Reshid to speak with us. Thank you, Doctor. Please go ahead.
Okay, thank you to all. The COVID-19 crisis in Iraq had come in a very critical time, especially in a country that like Iraq, who have a lot or full of problems and full of crises. So next slide, please. Now, if anyone who may not know who is the Red Crescent, now we have been established in 1932 in Iraq and recognized. We have a lot of partners from the movement and from the outside the movement. Next, please. Now, the facts in Iraq, now, you know that it's a small country with a 40 million population, but it has a lot of issues to deal with. We have internal displacement, we have migrants, we have Syrian refugees, we have high poverty line, and everybody knows that there was a demonstration and against the government that caused almost a shutdown. prior to the COVID crisis that led to the resignation of the prime minister, which had more impact on the socioeconomic status of many of the people in Iraq, because added to it the high unemployment rate. We have, besides pollution, damaged building, we have a lot of issues to deal with, and then super added by the COVID crisis. Next, please. Now, the COVID crisis first was acknowledged on the 21st of February. The first patient was his patient 0. He was a traveler who came from Iran to a visit. The countries had been involved through Najaf, the first kind of places that have shown COVID-19 is Najaf, Sulaymaniyah, Babel, and Baghdad. Now we reach 772 cases and 54 deaths, and we are the highest in all the Arab countries, East Mediterranean, after Iran. Now, the cases, how it's handled by the government is they are confirmed into 4 categories. The first 2 categories are hosted in hotels, and some of them are hosted in locations just like how you can call Marja'iyah schools, which is a school that run religious studies. But now, since all the studies have closed down, they are using them to host the suspected cases or the contact cases. The hospitalized are the one who confirmed with CPR or the one who need an ICU unit. If you know that on the 9th of March, there was a declaration by the government of gradual lockdown, schools, government building and everything, and then it developed into total curfew. And this curfew is extended almost on 10 days or on 2 weekly basis. Now the government is asked for help. The Chinese came, they delivered to them 3 CPR labs, because in the past we only have 1 lab in Baghdad. None CPR available anywhere in Iraq apart from that. So now they added to the service 4, and they are running now more number of screenings starting from the 31st of March. They decided to go door to door, especially in the most involved areas. Okay, next, please. Now, what are the challenges that everybody's facing in Iraq, including the Iraqi Red Crescent? First, the quality and quantity of Iraqi services. Now, we have 45,000 beds in the Iraqi Ministry of Health, which is for 40 million, and make the calculation. So in normal cases, they doesn't fit. 400 beds are ICU units, which have none of them a negative pressure unit. Many of them, they don't have a gyroscope. PPE is shortage in the staff. We have almost 2,000 staff that for 2,000 staff and 100 doctors for the ICU units. The dead body management is by itself as a crisis. Now it's raised, and there is a problem between the recognition by the government that it should follow the WHO, treated as an Ebola cases, and some say no, because this is a virus, it can die easily if it's buried. So we have a big issue here. Psychology, many of the people who doesn't trust in the government, the announcement, the messages is given about how to avoid coronas, stick to the curfews, so it's totally uncertainty because they lost the trust in the government. And the other thing is a stigma. We are having many cases and many people who, as if it is an STD disease or something, they are very worried about being called a corona carrier. And because of the large curfew, we have a negative impact causing poverty and food insecurity. Next, please. So the COVID response crisis has been associated with many of the pandemic diseases specialists, and we are joining the health cluster with the WHO, UNFPA, and many other organizations. We work on safer and protecting the volunteers and the staff in running, and the awareness and education happens that even before the announcement of the first case, when we heard that the Chinese have a problem with it, we started to change every message and awareness to the people and to make it to see that be aware certain outbreak may be on the line, especially in the camps, in the schools, when their schools was on. Then we distributed hygiene kits. Now we are in this phase of scouting communities looking for cases. We continue to pray and for the stigma and uncertainty, mental and health psychological campaign. And now we are trying, within the next week, we'll start food distribution of parcels for the vulnerables. Next, please. So this is what the Iraqi Red Crescent have done in targeting more than 4 million through the aerosol campaign, sterilization, and 900 volunteers and staff was in. Next, please. Next, please. This is a picture can show you. We went into prisons, we went into schools, we went wherever it's available. We can reach the people. Some of the people didn't have even internet in a very rural area inside Iraq, so they cannot use the social media. So we went door to door to give them information. Next, please. Next. So bottom line, it's a crisis hitting everyone. But there is hope. We will go through it. We will try our best to rearrange. We have a lot of partners to help us in this crisis. So as we say always, the power of humanity will prevail. And yesterday and between Liverpool, the past week, you can see this rainbow by kids. Stay safe, be kind, and keep smiling. So it's a pandemic that hurt the world very hard. We're sorry for all the losses. We hope everybody stays safe and sound, and wishing for the best. Thank you.
Dr. Reshid, thank you so much. It's been really great having your voice here. Actually, almost every week, I think you've been in our audience or speaking. So thanks for giving us that perspective. You mentioned the prisons, and I wonder if you could just expand a little on your thoughts around prisons. We've had a huge outbreak in prisons in the US, including in New York. And there's a lot of momentum around trying to decongest the prisons. Can you tell us a little more about the work that you did there and your concerns or potential solutions for the prisons?
The issue is part of the work of the Red Cross is the, we call it Restoring Family Link, which is that we go to the people who are prisons. It started with a prisoner of war, and then it changed into the prison arrest and all of that. So we have a good connection with the Ministry of Justice, the Ministry of Interior in Iraq. So what we do every now and then, besides going to the prison, education about first aid, we have what we call community health project. We do found that because there is no sanitary condition in the prisons, at least inside Iraq. So what we did is that we helped them in aerosols, giving them the instructions, and yet we see no case because many of them were in lockdown and all the family visits were shut down immediately. So still far till this minute, there is no case inside the prisons of a COVID. We are hoping that it continue the same, but there is now a big talk in the Iraqi government, the campaign led by the president of Iraq, is that we can let them out because we don't want them to have any chance of infection. So we are still coping, trying to keep this situation under our radar and trying to see what will evolve.
Great, thanks. Dave Harden, I want to turn to you for a question, if I may. So you are
Yep.
former deputy mission director in Iraq, if I'm correct. And
Yep.
I wonder, like, how can we get more attention to what's going on? Even frankly, every Friday we've been having these panels and we usually have 100 people attend. And I see this week, I'm super grateful for everyone who's joining. So thank you for joining us. But how can we get more people interested in what's happening and what can we be doing to support Iraq and other places? And we'll get to other guests in a second.
I mean, I think we put substantially further and kind of link in to the NGOs that are operating across the Middle East. I think we would need some Arabic language capabilities as well, depending on what the target audiences would be. I would also try to expand it beyond to certain really, really fragile states like Yemen. where I deeply worry about the risks. In Gaza, very high dense populations, in the refugee camps in Turkey and Jordan, and of course Syria and the challenges that surround all of that. So I would be happy to help amplify this, and if you want, we can really work about trying to, instead of having hundreds, trying to get thousands connected in.
I was looking at the map this morning and I saw in Gaza there's 171 reported cases. I saw in Syria only 16 reported. Dave, what's the likelihood that that's actually the truth versus capacity to report?
Yeah. So there's some irony here. Let me just begin with Yemen. So Yemen only reported its first case a few days ago, and you and I have worked on Yemen together with cholera. So we know that it's not the result of a great healthcare system. It's the result of the fact that it's completely disconnected in a state of high conflict, and so they're not even kind of plugging into the international system. That's the same with Syria as well. Gaza, while it's super high risk, there is an infrastructure that's there, and there's the UN, and there are the UN structures that are in Gaza as well. And so I would expect that in some ways, Gaza would be able to manage it better than, and not well, but better than what you would have in Yemen or Syria.
Great, thank you so much. I see that Dr. Aryiana Jawad has joined us. She's just connecting her audios, but I'm going to turn now to Dr. Yaroup. Thank you so much for joining us. Please go ahead, and Kerry, I think you can show his slides.
Thank you so much. It's in Jordan since the mid-March. Jordan has completely became, like we say in the region, on the heart of one man. And all the country, camp or non-camp, as you know, the Syrian, Palestinian camps in Jordan, they are applying the same policy. The complete curfew is everywhere in Jordan. Only medical staff with special permissions and the supply chain are allowed. We don't use cars at all. We walk to the nearest by. The queue line is 1 to 2 meters distance between people. Until now, Jordan has, let's say, registered around 299 until yesterday. We expect some increase today. And unluckily, we have yesterday a different story. Since mid-March, everyone who traveled from outside Jordan to Jordan and is applying like a personal quarantine for 2 weeks. As we have expected the incubation period to go up to 14 days, as declared by the Ministry of Health. But yesterday we have a case, a doctor who has quarantined himself like for 2 weeks, but he has shown the symptoms and the signs and the positive test after the 2 weeks quarantine. Jordan has closed all the road, all the ports between us, Syria, Saudi, and everyone, and the main airport in Amman in 18th of March. And in here we have recorded cases with symptoms after 2 weeks quarantine. Now Jordan is completely is going toward mid-April, full curfew, and all the environment in the region or on the ground is becoming more military. The army is controlling all the area. Also, luckily for everyone that we have the red zone in the north, let's say west, middle west, north of Jordan, the city of Erbil. And we have like a complete isolation of that area. Even some of my staff who work in Zaatari camp, for example, they cannot travel to the camp. So we have, as NGOs, we have some shortage in the permissions or licensing to the non-medical staff, the supply chains, drivers, different other categories of staff. And we have a lot of international organizations whom they have left Jordan through the airport before the closure of the airport, and there was some evacuation for some staff because unluckily they even cannot get easily permission to work, and we have to depend on the local staff in Jordan. And you know, the phobia of corona and the let's say the figures of the death and the high numbers of death put everyone in the big question, or stay or leave. And many of us as let's say humanitarian workers, we think about the no harm policy. So a lot of programs are almost shut down. A lot of distributions are strict. A lot of awareness program. We have we have difficulty in distributing even hygiene kits to the people because it's not easy for big companies to get permissions to move in Jordan, and we need to depend on the UN system completely. Partners of the UN, they can to somehow get some permissions with certain rules. Unluckily, Jordan is a small village compared to United States or to the big countries worldwide. We are 10 million people, including refugees. Luckily, we are one family now, and we are following the same orders. We don't have two systems for camps or non-camps. The most important things is that until now, we have recorded 0 cases of infection within the refugee community, either camp or non-camp. We have some other nationalities traveling to Jordan. Very good that the government has decided all these treatments are free. Quarantine in the Dead Sea and the 5-star hotels for travelers free. Everything is free. The salaries of people are moving and coming. Payments to the bank is the same. So I think we are applying a very strict model of quarantine, but also almost everything is available to the people. Cash flow, the supply chain, the food items. We have, as NGOs, also problem is that all the PPEs are in high price. There is big shortage. Also, we need to have some wisdom on how to use them, when to use them, to whom. We as medical NGO, the Jordan Health Aid Society, we also apply very strict, very tough procedures because we don't want also medical staff to be a source of infection spread. And we depend on the least exposure, the least crowding. Even we distribute family planning items to the houses of the people through a very sterile and expensive manners now. And this is the situation. I have shown on my slide a picture for some volunteers in the Zaatari camp, because Jordan is giving people to walk, to buy things during the day from 10 to 6 p.m., from 10 a.m. to 6 p.m., including the same in the camps. I think we are until today lucky. In spite, we have around 299 cases, COVID approved positive. And we have also cases of death were 5 until yesterday. And we have a lot of cases that are healed, or they build immunity and they have left hospitals with negative test for the virus itself, the PCR. But the unlucky point is that the incubation period has shocked us that we have cases shown positiveness and symptoms after 2 weeks of quarantine. Thank you.
Thank you so much for your insights there. It's very helpful for us to hear directly from you. I have a couple of questions that maybe I'd like to pose to you and Tara, and also Amir, who Amir is in Boston, but I know following the situation in Egypt very closely. A couple of things. We don't really have a good sense, or at least I don't, and I'd love you to tell me more about how many people are actually being tested. Because what we can see is more the positive reported cases, and understanding how many people are actually getting tested can really help us understand where we are on the exponential curve. And we, in the US, we very early had, celebrities and movie stars getting tested when ordinary people couldn't get a test. And so we wonder about, are there disparities that might be happening in testing? Could each of you give a comment on how people get access to testing and what you think the prospect is for that? Maybe Amir, could you jump in first and then we'll go.
Yes, I think that it's an important point. Certainly in Egypt, the earliest cases of positive COVID confirmed cases connected to Egypt were in tourists who were in the Nile River cruises or in the Red Sea tourist areas who became ill and then tested positive either when they went back to Europe or when they received medical care in Egypt itself. And just like in the US, there are kind of more high profile cases of people testing positive in Egypt. We had some of the leadership in the Egyptian military test positive, or at least this was what was kind of leaked to the media. When that happens, there's a concern that if there's a cross-section of society that has access to testing that tests positive, then who knows what the rest of society's true positive rate is. So I think many people are concerned of that as well. And then before I finish, just something Dr. Yaroup said is very important, about the incubation period. Early on in this epidemic, the WHO announced an incubation period suspected of 14 days based on what we know from MERS and from the first SARS virus. But the earliest studies that we have on incubation period show that it could be 1 or 2% of people can incubate much longer than 14 days. And so when we are locked on the 14-day mark, we may actually end up missing some key cases. And so the case that Dr. Yaroup just said of a physician turning positive after 14 days shows us that we can't be kind of locked into what we know about the virus, because what we know about the virus is actually very little.
Thanks, Amir. Dr. Tara, can you comment on testing, but also, I think, thinking of the Red Crescent and some of its role about contact tracing? I think in the US and in Massachusetts, there's been some debate about how capable we are of contact tracing now because we have so many cases. I'm still heavily in favor of doing aggressive contact tracing. Is that something that's happening right now in Iraq? Are you guys involved in that? You're on mute, so let me.
Okay.
Here we go. Thanks.
Now, okay, great. The issue is in the beginning, the Ministry of Health was, since it's running the CPR, it was very, very, very rationed to the lowest degrees because they usually gather a sample of 10 patients before opening one kit. This is the beginning, and most of the cases were admitted to the hospitals based on clinical diagnosis, and then a test will be made to them. But things started to evolve after the declaring of the lockdown on the 15th of March, when the CPR kits come flowing to the Ministry of Health. They received almost 50,000 kits from the Chinese government right now. So they're running almost between 1,000 1,000, 1,500 tests per day, and mostly to the contact. The contact, usually all of them have the information. The issue is the Safa in Baghdad, for instance, in Najaf, in Erbil, in Sulaimania, they're almost gathered in very close zones, and they are very family linked. So it's very easy to track them down. And that's why now a more widespread screening door-to-door mission happening, especially in these high level of areas that have families of a high number of contact or positive cases. But in the beginning, it was the worst case scenario. You even if you have to run the CPR from Sulaimania or from Basra, you have to carry the sample to travel almost 1,000 kilometers to reach Baghdad, forward, backward, to get the result and go back by phone and call them, say, yes, this guy is positive or not. But now things improve with the new kits and adding 3 units for CPR testing. Thank you.
Great, thank you. We're still working with Dr. Jawad to have her audio connected, so we will come back for her comments as soon as we can do that. I was going to ask Dr. Walton to jump in on the built health environment. Dr. Yaroup showed us some photographs. Can you talk a little bit about your concerns for people living in camps, living in places where it's hard to socially distance, and what you've been working on in terms of creating ideas for structures in that context for healthcare?
Yeah, absolutely. Thanks, Dr. Ivers. And I think this has come up on a couple of our Friday sessions. I think our panelists I would love to hear their commentary. I think one of the concerns that you all have and that we have is how do you, in such dense areas where there are curfews, as Dr. Yaroup mentioned, and people with who are living in camps, how do you think about transmission and prevention of transmission, or mitigating transmission? Thankfully, I think Dr. Yaroup said there has been no recorded cases in the camps thus far, and I think it sounds like Jordan is implementing significant methods to prevent that. But and I think preparation obviously is important, and so I think I'd be curious to understand Dr. Yaroup's perspective on what mitigation strategies they have in place. I think the other concern is if there is a certain amount of people that do turn positive and that number sort of exceeds the built environment, the healthcare built environment's ability to effectively cohort patients, which New York is certainly, at least in the United States, is undergoing now. Italy, we've seen these examples. So what does a cohorting look like with those sort of supernumerary caseloads? And I think one of the things that I spend my time thinking about is certainly the built environment, thinking about COVID treatment camps, much like were implemented around the world for cholera and continue to be, as well as certainly during the 2014 to 2016 and then the most recent Ebola epidemic. So I think I'd be curious to understand from both Dr. Reshid and Dr. Yaroup sort of what their perspectives are on sort of how to cohort patients effectively and sort of how to mitigate spread in the camps, especially with the potentially much greater population density and an inability to socially distance, given the environment.
Okay.
Dr. Yaroup, go ahead, please.
Thank you so much. I will tell you, during all this crisis in Jordan, we became like one nationality. All are one entity. We are not refugees and locals, let's say rich, poor, whatever. We start to act with a very tough, united government on higher level managed by the king himself. And we start to see the king every day almost on TV. And he has shifted all this, let's say, politicians, regular traditional politicians, away from the scene. We start only to see very strict rules that are the army. And you know, we have an empire of what we call it the Royal Medical Services. They have isolated the last, before the 18th of March, they have taken around 15,000 people to the Dead Sea in the five-star hotels. And the supply chain of food is controlled by them, the infection control. The rules became very tough. And people, they like it. It's not a human rights penetration at this point. It's the life of everyone. And we have followed the same order, me and the Syrians. I am as a doctor at Jordania, let's say, and what I have to, do you hear me? Yes.
Yes, we can hear you.
And and the second thing is that Jordan has not isolated all these thousands of people in facilities, like in hospitals. We have selected a very unique model that we have taken hotels, because the health system, the public system in Jordan does not have this number of isolation rooms. And the Israelis on the other side of the river, they have also done the same model. They are isolating the suspicious cases, travelers, people coming from outside. Now Israel is applying a huge evacuation of Israelis to Israel through private jets. So they are sending them in the same model like Jordan, hotels on the Mediterranean. We put them on the Dead Sea. The second thing is that we have 80 inspections or epidemiological investigation teams, 80 to 10 million people. Jordan is offering also, if someone, as you know, is that people can become, even in after 2 weeks, they become positive. So to whom we do the test, the rules are managed by a completely independent medical team, managed by senior staff. And all these cases, they do, as you said, to the direct exposure. We go to the symptoms, people declare, we have free numbers, they reach. Many people, they have applied personal isolation, private, in houses. People come, and even after they have left the hotels, the structure, the instructions were very clear. They have to isolate themselves away from families for another 2 weeks. So the high level, I think also the phobia is important. The phobia is important to manage this chaos within on the community base. And Jordan has not so much PCR tests. We have early in the crisis, we have around 4,000 kits we can do. Now we have 20,000 with a capacity to do 60, but we need some capacity building. So the government is working, increasing the level. We are doing now around 400 tests daily. Early in the crisis, we are doing less because we don't have this capacity. Now, in Jordan, if I want to give you some figures, how much we have around 12,000 beds in hospital in a 10 million. Jordan, luckily, medical sector is with certain capacity on private sector level. The government owns 40%, but they can buy service from private sector. Jordan has around 1,000 something ventilators. We are buying from Germany or Singapore something like 200. And we have 5 deaths out of 300. So we are talking about 2%, let's say, death from this group of people whom are completely positive and discovered. Out of 10 million is strict number. The strict policy is very important. If people, they don't look that this is a human rights issue, the army in the field, no. We are in the Middle East, in Jordan, with all this strict policy, we are happy. Yes, The prices are high, the supply chain, sometimes you don't find what you need to your family. But I think we are talking about a COVID generation from now
Yeah,
on.
thank you.
It's
Yes,
new
COVID
future for,
generation.
yes. And I like
Thanks,
to
Dr.
use
Yaroup.
this
I'm sorry,
word.
I'm going to, thank you so much. I want to let everyone know that we're very happy that Dr. Aryiana Jawad can now, you can hear us, Dr. Aryiana, and I think we'll be able to hear you in a second. Great. I'd like to go ahead and give you the opportunity to share your comments with us. Thank you.
Yeah, well, I don't know. Kerry, hi, how are you? I'm so sorry. This is just a minute. This something happened. So hello for everybody. This is very good opportunity to have me with you today. Of course, I'm from the Kurdistan Federal Region, north of Iraq, inhabited by more than 6.8 million people, mainly Kurdish, and have a very wide border with Iran. Of course, next slide. Sorry. Next slide. Oh, slide. Slide. He's oh, sorry. Something. Slide. For COVID-19 cases reported by Regional Ministry of Health about since 1st January. Something happened. I don't know. Slide. Okay, it's about 200 cases since January yesterday, and about 62 cases recovered, only 2 deaths, 137 cases active in a hospital, general governmental hospitals, and we have, of course, 22% of the cases are traveler only, and the other get infected from. Can you see me?
Yes, we can. Yes, we can see your slide.
Yeah. Okay. For tests, we use PCR tests for more than 8,000. Not like Georgians. We use testing peoples, a lot of peoples, and only 2 cases get positive. The other slide, it is about the distribution of cases around the cities and the governorate. You see this is a Suleimania, high numbers of cases reported there because of wide border with Iran, and we have only 2 deaths of the cases, and this is a cumulative case reported according to the days before. You know, Kurdistan region was the pioneer among the world for taking protective measures. And I think the political will for combating COVID-19 can be summarized in 3 fundamental issues, which is public involvement, preventive and protective measure, and preparation for the next step. What is the measure? The speech of His Excellency Prime Minister Masroor Barzani, when he is talking in his speech about the COVID-19, he said that we do everything possible for your safety. We have an obligation to you, and we will take any decision for your well-being, protections, and addressing everything needs for everyday needs, and ask the people to complying with the public measures and reward the effort of the interior and health services. And he promised to be transparent and updating the citizens. Look at this speech. This speech is obligation with the peoples, take care of their safety, and they can do whatever. So what is the public, how involved the public here is to take, of course, the ministerial committees, early emergency budget, suspend governmental bodies, closing school, universities, limiting public gathering, and transparency with the federal government, between cities, between the borders, and less for exchanging is only for medical and food requirements. Then ask for public holiday, providing local governmental funds. And what happened here is government ensure access to the essential goods to prevent And he also prevents mal prices. Media campaign, for surprising media campaign for superimposing peoples regarding COVID-19, what is the risk, protection, signs and symptoms, and there's a hotline, decreasing hotline for connections with in the Ministry of Health. So her instilling in the mind of people about the national health security is very important. Everybody know what's COVID-19 and what's the risk of COVID-19 on the health. Of course, transparency in swifting and delivering data. And there is a test, PCR test. Everybody can get the test for free from the governmental centers. And about the prisons, he takes care of the prisons. We have IDP and refugees, what our government done. Of course, in Kurdistan, we have more than 1 million people, IDPs and refugees in 11 different camps. He promised to take care of the precaution in these camps and refugees with the local authorities and international organization. Here you can see one of the Sinjar. She is talking with the channel, Kurdistan channel, about the precautions and commitments of health instructions for combating COVID-19. So the first, you have to involve peoples in your journey. Second, the precaution and preventive measure to contain this jeopardy or this pandemics. This is in form of quarantine. The quarantines, we have 4 governmental public position for quarantine, and more than 5,000 people stay at this position for more than 14 days. And at the last days, they tested and they let them to go. The quarantine for people who get contact with infected people or return from ports. And not only quarantine for designated position or special position, but also quarantine for cities and towns. We have infected person in towns for 5,000 population. Other like Sibiran, the other one is about 27, more than 27 population. There's quarantine by the government. And here we see the president, the health ministers go to make sure everything is good, and testing because of this town having infected cases. So the contact persons will be quarantined, and all the towns will be quarantined and tested randomly among all these towns. The second policy is curfew, finally, imposition of the curfew. Curfew is started, or what we say, it is home quarantine, which is adopted the 2nd of April by WHO. We start since 14 March, and the quarantine whole cities, shut down all the cities with government ensure access to the medical and food requirements. For preventive measure is prohibition or prevent entering people. This is preventing entering the traveler who visit China from 14 January, or preventing interest traveler went to Iran. We were in Iran since 5th February, and setting deadline for returning back to the country. And this visa is prohibited for designated countries like China, Iran, Italy, and there is a medical screening point for all entries. The third one, which I think the government is thinking, it is a preparation for the third stage. This third stage, in order to face this pandemic, start to enriching the health system by setting a hospital, either it's building new hospitals. We have different buildings now finished in a different governorates, hospital bed prepare for COVID-19, and staff training, equipment like PPE and other medication, and the conveying with the science and updating about the coronavirus. And government should and resetting the economy, priority of the economy, and should be resilience in handling the challenging which we're gonna face during the upcoming year. Here, the parameters.
Thank you so much, Dr. Jawad. I realize we just have a couple of minutes before the top of the hour. I wanted to maybe pass to Dave Harden for any closing comments. And I also want to really sincerely thank all of our guests for joining us for such a rich discussion. Dave, closing thoughts for us?
Yes, thank you. Thank you. Well, first of all, I thought this was extremely valuable. And to the extent the whole world, or at least the Middle East and the United States, can see this next week, it would be really helpful. I worry that we are talking in a way to states and health systems that are stronger. I have great confidence in Jordan. I go to Jordan all the time. I know Jordan extremely well. I lived in Kurdistan, and so I know the capabilities of Kurdistan. The risk factors for the Middle East are going to extend beyond those states or those regions that have strong health systems, and the real risks are going to be in the most vulnerable countries with the most vulnerable populations. And then the kind of bounce back or the second wave of coronavirus out of those countries will continue to vector throughout the world. So I remain deeply worried about the most vulnerable. Thank you, Louise, for also hosting this.
No, thanks very much for joining us. Thanks to everybody. Thanks to our audience. Please send us questions, ideas. I'd love to get this panel back together in about a month. I think it's going to be very, very interesting to see how the epidemic evolves in the Middle East as well as around the world. So I hope you'll be willing to join me again in a few weeks. Thank you very much, everyone. Stay well out there, and we'll be in touch soon.
Thank you all. Have a good day. Bye.